It's an honor to be here. I've taken care of patients with HPP, so it's really great to see such a full room of people that are really invested in this and invested in helping take care of all of our patients with HPP and raising awareness and such. So thank you for having me. As an introduction, I'm currently at Vanderbilt University Medical Center. I primarily work in the Children's Hospital, so it's called Monroe Carroll Jr. Children's Hospital at Vanderbilt. There we go. I wanted to go over pain in general and how that relates to hypophosphatasia and how that relates to comprehensive pain management. So we're going to go over what is pain, how it relates, kind of looking at the biopsychosocial model of pain management, and we'll go deeper into that, and then what comprises multidisciplinary pain management. So what is pain? So it's defined as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So that's probably a little bit different than what a lot of people think of is the definition of pain, because it's equally a sensory and emotional experience in this definition. And there's this sensation is associated with actual or potential tissue damage. So we're learning more and more about pain, and that pain does often come from an anatomic or an organic cause, but it can be also without tissue damage. So it can be from a neurologic or other cause as well. So we're learning more and more about that. The important thing is that pain can be invisible. So it's really important to validate pain because pain cannot be made up. It is subjective, but it's really important to validate pain because all pain sensations are very, very real, whether they're coming from actual or potential tissue damage. So this is just a schematic of the different types of pain and their possible etiologies. So we're looking at various sources of pain and how we can characterize those types of pain. So you see there's nociceptive pain, neuropathic pain, and nociplastic pain. Nociceptive pain is that traditional pain that we're all familiar of, things like from noxious stimuli like pressure, heat, pinprick, stuff like that. Tissue trauma, any type of cuts, lacerations, inflammation, as well as from surgery. You can also have nociceptive pain from your internal organs as well, and other parts of your body, like your musculoskeletal system, and from various injury as well. So that's what comprises generally what nociceptive pain is. Neuropathic pain is usually considered pain that originates from the nerves and the nervous system, usually from specific nerve injury. You might hear people talk about neuropathic pain generally as any nervous system type of pain, but that is actually characterized now as nociplastic pain in the last decade or so. So nociplastic pain is not any clear tissue or nerve injury, but there's other processes that are going on, like peripheral nerve sensitization or central sensitization. You might have heard those terms before. That's kind of where the nervous system, either peripherally, so kind of like in our limbs, in our peripheral nervous system, even though there's chronic pain there and there might be tissue damage, over time, other nerves in those areas become sensitized as well, and they can produce a pain signal even without an actual tissue damage. Similarly, in central sensitization, which you might have also heard of, that's where your central nervous system has had chronic pain for so long that it starts learning and starts creating more neural pathways that increase the pain signal. So that's what kind of nociplastic pain is. So when we think of pain, we kind of break it up into those three areas. You can also see that there's many sources of nociceptive pain that may also overlap with neuropathic pain. And I would say that I didn't make this schematic, but there's definitely other sources of pain that kind of point to nociplastic pain as well. So all of these kind of overlap with each other. this is just looking at them again. There's overlap between these types of pain, but there's also very specific features of each one. So the things that I want to just point out from kind of looking at HPP, and we'll talk about it a little bit more, is in nociplastic pain, that's more of like this central and peripheral sensitization. In neuropathic pain, that's if we have any neuropathy or neuralgias or radiculopathy, that's when nerves are irritated and cause kind of those like pressure or those electric sensations, or may even have like a burning or a tingling sensation. And then nociceptive pain is that traditional type of pain that we all think about when we think of pain. We all know that pain is a significant part of HPP. In our previous presentations today that were excellent, also pointed that out, so I'm not going to talk too much about it, but we all know that there's a significant burden of pain in HPP, so that's why we're talking about it today. Let's see here. This is a schematic by Dr. Seyfried that is actually here today. So you can see that everybody's referencing each other's research and studies, which is pretty cool. But it's also evident that there's not enough evidence out there as well. But this is an overall talking about all of the different features of HPP, and I just highlighted here all the areas that can cause pain or are related to pain. So there's a lot of areas of HPP or symptoms of HPP that can be related to pain. Specifically, I just want to look at some of the radiologic findings that you can see in HPP, especially as a presenting symptom with bone pain. You can see those metatarsal fractures or femoral fractures. And so the femoral fractures are on the top there that have been already stabilized with some intramedullary rods. And you see down there an x-ray of a foot that has a very subtle stress fracture as well. You can also see calcinosis everywhere. So you see, and we talked a lot about renal calcinosis or calcinosis in the eyes. But you can also get calcinosis in other areas. So this is in the back, kind of near intervertebral discs and the epidural space and whatnot. But there's multiple areas that the HPP can affect. Let's see here. So how do we treat pain? We have to conceptualize pain on a bigger standpoint, because a lot of times we just think about pain as this subjective numerical scale that we have to decrease. But that's not the only portion of pain that we need to address, because pain is not only significantly associated with decrease in overall functioning, so daily functioning like going to school, going to work, being able to walk around, go shopping, do pleasurable activities that you like to do, like your hobbies. So there's a lot more to pain treatment than just trying to decrease that pain score. And I think all of us have known or heard over time that we're kind of moving moving more away from the pain score and looking more about functional goals, because that's kind of should be the the goal of treatment of pain, because we really want to increase function, because that's a little bit more of an objective value and allows you to kind of live your life as you would like to live your life, rather than just trying to decrease the pain score. So we're going to talk a lot about that. So we do have to conceptualize this on a bigger scale. So when we think about treating pain, we use something called the biopsychosocial model of pain management. So really, we think about pain emerging at the intersection of these three areas. So obviously, there's a biological side. So in HPP, that's where you have fractures, pseudofractures. You might have calcinosis. All these things go into the biological causes or contributions to pain. But as we know from the definition of pain, there's other parts to it as well. There's definitely a psychological part, and I want to make it clear that psychological doesn't mean that you're making it up. Okay, that's a misconception that a lot of people have, because when you say psychological, it's like, oh, it's just in your head. And that's a very important distinction that we have to make, that it's not just in your head, but because pain is a part of the nervous system, and the nervous system is responsible for a lot of things, not only for the sensing things throughout our body, but it's also telling our organs and our body what to do, sensing emotions, mood, cognition, learning, socialization. There's this very strong mind-body connection, and that's actually physical and real and not just floofy. But it's very real, so we have to think about it from that standpoint too. Not only are there things that we can do from a psychological standpoint to help with pain, but there's secondary effects from having disease or pain as well, like anxiety, depression, that go into this. And we'll go a little bit more into this as well. And then the other part of the biopsychosocial model is the social part. So thinking about how the patient functions within their family unit, thinking about how other factors outside of the home might influence how they process and have pain, whether or not parents or other people in their life can help model pain behaviors, whether or not there's cultural beliefs or socioeconomic impacts to not only their pain experience, but how they get their pain and their disease treated as well. So you'll see biopsychosocial model in a lot of different treatment of things, but we really focus on this in pain treatment because it's so important. Now there's other theories as well. One of the ones that we also think about is the ecological systems theory, where the patient's situated not only in the context of their family system, but their broader social environment too. So you see all sorts of things that can influence their experience of not only their disease, but pain as well. So whether or not it's their religion, their school, their family, or the things that they see on TV, the friends that they have, the family, distant family members that they associate with, but also outside of that too, the ecosystem of our healthcare system that they have to navigate, which can be very challenging at times. So we kind of think about pain both on the biopsychosocial model as well as an ecological systems theory. A part of this is really thinking about how when we treat pain, I focus on children in pain because I mainly treat children, but this applies to adults as well. But really treating the whole model or the whole family is really, really important because not only do they learn from their adult role models or other people in their family, but they can also model those behaviors as well. And those people can actually play a significant impact on adjusting their pain experience and hopefully improving their pain experience. So when we think about pain treatment, how do we apply these biopsychosocial models and the ecological systems theory? So we really want to ideally have interdisciplinary care. So we often think about multidisciplinary care, meaning multiple disciplines. In my field, it's the physician, PT, OT, pain psychology. When we say multidisciplinary, we think about more about that as kind of working side by side to take care of the same patient, whereas interdisciplinary refers a little bit more about us really collaborating with each other and discussing with each other. So that'd be ideal if you can find a team that has interdisciplinary care, but multidisciplinary treatment is kind of the mainstay of this. Pain treatment involves all of those things. So you see medication management, sensory regulation and sensory motor integration, pain psychology, physical conditioning, and that all leads to hopefully successful return to activities and achievement of their functional goals. But at the start of this is really pain neuroscience education. And so we've already started that at the start of my talk as well today. We started some pain neuroscience education. So when I and our team evaluate each patient thoroughly, we then move on to giving them some education because that really informs what their treatment's going to be. So what does some of that education look like? We define pain in different ways. Sometimes we use different analogies or kind of phrases that they can relate to. One of the easiest ways to think about pain is the body's protector, right? It's sensing, there's sensations in our body that can tell us whether or not there may be some danger in our body or our surroundings. So our nervous system is consistently picking up danger signals and safety signals in our body. And when there's an imbalance of danger signals, so more danger signals and safety signals, then there is a pain signal that's produced. And then our nervous system, and we have to react to that. When we think about this from a neuroscience point of view, pain is activating our sympathetic nervous system or our fight or flight nervous system versus the parasympathetic nervous system, which is kind of like our rest, digest, relax nervous system. So some of the things that from the biopsychosocial model that increase pain are some cognitions, like there's something wrong with my body, or there's something new that's wrong with my body, or I have so much pain I can't get up, or I have so much pain that I can't go to school. There's a lot of emotions that go into that. There's fear, anxiety, hopelessness, depression, and then a lot of behaviors as well. Activity avoidance, social withdrawal, and then obviously there's biological features as well. So in HPP specifically, like fractures, bone pain, inflammation, etc. When we try to manage pain, we try to decrease those danger signals, but also increase those safety signals. And when we do that, we're allowing the body to function better as well. So we're kind of emphasizing the parasympathetic side of our nervous system. So in the biopsychosocial model, again, what cognitions can we help with to really signal some more safety signals to our body? So things like, I know what is happening to my body and I'm treating it. So in this case, I know that I have HPP and I'm taking the right steps to treat the HPP. Even though I have pain, I can use relaxation strategies or other brain-based strategies to help regulate my nervous system. So that's kind of living with the pain and also improving our pain experience. Some emotions that are helpful are hope, self-efficacy. Some behaviors that are helpful are using physical activity and a graded approach to increase function. And then biologic things are things like the actual treatment of HPP and using pain medications, which I'll go into as well. Another part of the pain neuroscience education that's really, really important is looking at the fear avoidance model of pain. So this is kind of a cycle that we get into when we have chronic pain, where we have an onset of pain, then that leads into a fear of pain, that leads into activity avoidance, that eventually leads to deconditioning of the body, and that can have further worsening of some of those pain emotions like depression, hopelessness, and heightened fear of pain. And then that keeps on going in this cycle that is very, very difficult to get out of. So part of pain treatment is trying to get someone out of this fear avoidance model of pain. And the way that we do that is through this interdisciplinary model. So at each point of this fear avoidance model, we have potential exits. So you can exit this endless roundabout. So at the fear of pain, we can change thoughts and beliefs about pain. When we're avoiding activities, we can actually slowly grade activities up so that patients can tolerate the activities and get some enjoyment out of the things that they like to do. And graded, you're going to see the word graded a lot in this presentation because we definitely want to meet patients where they're at. We're not going to have someone that feels like they can't get out of bed and tell them to run a marathon tomorrow because that's impossible, right? So we're going to meet them where they're at and push them a little bit, but get them there slowly so that they are able to achieve their goals eventually. Let's see here. At the exit, at the deconditioning point of the body is building strength and endurance, activity, pacing. And then at the depression and hopelessness side, kind of treating co-occurring psychiatric symptoms and sensory processing differences. And especially as pediatric providers, we do this through a developmental lens as well. So we know that HPP can affect a spectrum of ages, so we have to tailor our plans to that. The other thing that I want to talk about with activity pacing and graded exposure to activities is that one thing that we really want to avoid is something called booming and busting that we often talk about, where you might feel really good one day and do a lot of activity, and then for the next few hours, for the next few days, or even weeks, you bust and you can't do anything, and then you feel good again and go back into that cycle. So that's instead of a circular cycle, that's kind of like a sine wave cycle, and that doesn't get us anywhere because we want to get from where we are to a specific goal, and going up and down doesn't get us there. Whereas a graded approach is kind of like more like a stair-step approach, and that gets us eventually to our activity level that we want. More arrows, sorry about that. So again, we use this interdisciplinary model with an interdisciplinary team in order to eventually reach our goals. And another note, again, to emphasize is that we want a successful return activity and functional goals, and we're not focusing necessarily on pain numbers and things like that. It's not that we don't care about those things. We don't want you to suffer. We don't want patients to have pain all the time. But one of the objective and core things that we want to do is get them back to the lives that they want to live. And oftentimes, especially when we have peripheral nerve sensitization and central sensitization as well, the return to function actually does help the nervous system deprogram some of those sensitization or the sensitivity, and that allows the pain to go down as well. So we're not ignoring it, it's just not the primary focus like it was maybe 15, 20 years ago when pain was the sixth vital sign. So, you're probably looking to me, since I'm the pain physician, at medications and talking about that. So I'm going to talk a decent amount about that. But just thinking from a global picture, how do we approach pain management, especially when we're looking specifically at pain medicines? Again, medicines are one part of the picture. There's a much bigger picture, of course. But when we're looking at pain medicines, we want to make sure that we're starting with the medicines that can be effective, but also have very, very low side effects, especially when we're starting with mild pain or moderate pain. We start escalating when pain increases and those other things have failed, while understanding that side effects are a major part of this, and that we have to manage the side effects and the untoward effects of our medications as well. So we often start with non-opioids and some adjuvant therapies when we're in the mild pain standpoint. As we get to moderate and severe pain, we start adding opioids. We may add opioids or a lot of other non-opioids, and we may also do some interventional treatments as well, meaning like injections and whatnot. And I'll touch on all of those. So we really want to take a logical and a mindful approach to using medications. We also, in pain management and in medicines, use a multimodal approach, meaning using as many different medicines as possible to get effect out of them while minimizing the side effects and untoward effects of them. Just note that many of these medications are used off-label for pain, so they have primary indications for other things, and most are not extensively studied in pediatric patients. So your primary care physician may be uncomfortable with prescribing these, and that's why they might refer you to a pain physician or someone that's a little bit more well-versed in using some of these medicines. The different medicines that we use affect pain in different ways. We think about kind of stopping pain at the transduction phase, so from where the pain is being sensed, trying to stop that sensation. And we can use like local anesthetics and some other medications to help that transduction. We also think of medications or the pain being transmitted from the periphery into the central nervous system, and there's some medicines that can affect that. And then there's medications that kind of modulate the communication of that pain signal from your spinal cord into your brain, and then medications that affect pain perception as well. So that's where, with all the areas that we're trying to think about when we're choosing the correct medicine to start. Obviously, when we're thinking about medicines, the primary focus of pain management actually should be the treatment of the primary disease, for the treatment of primary disease. So in HPP, we know that we have a great medication for that that has been talked about. But really, when we're treating HPP, we really want to minimize fractures and pseudofractures so that we don't have a lot of tissue damage causing nociceptive pain. We want to improve fracture healing and bone mineralization so that fracture is not causing so much pain. Looking at calcium homeostasis and minimizing calcinosis, because that can lead to other effects down the line, like calcinosis in parts of our musculoskeletal system, especially our joints, that can lead to arthritic type symptoms or gout-like symptoms. So we all know about NSAIDs probably. NSAIDs are non-steroidal anti-inflammatory drugs. A lot of these drugs are available over the counter, but there's also prescription ones as well. These medications primarily inhibit some enzymes called COX-1 and COX-2. And by inhibiting those things, it prevents the downstream effects, which you see at the bottom there, from happening. So one of the main things that it does is decreases inflammation and pain, like you see in the bottom left there. But you can also see that COX-1 and COX-2 have downstream effects that are not pain related, and that can cause a lot of the side effects. So for the hemostasis, that means that you can have bleeding issues with the use of NSAIDs. There's GI dysfunction that can, side effects that can happen from NSAIDs as well, especially from chronic NSAID use. So we want to be careful of the GI side effects. And it can also affect bone healing as well. So we really want to be mindful with NSAIDs, even though we know that this is one of the most common medications that we use, especially in HPP. Now, this makes sense that this is one of the most commonly used medications because HPP does cause an inflammatory cascade of sorts, and that can decrease inflammation. And then with musculoskeletal pain especially, NSAIDs are really, really helpful. We do want to be mindful of those long-term effects. So if you're on chronic NSAIDs, you definitely want to work with your pain physician or your primary care physician to monitor for side effects like GI ulcers and things like that, as well as looking at kidney injury. And usually if you're on chronic NSAIDs, you should probably be getting renal labs at least yearly, and you're probably getting that anyway, as we learned before, as routine management while treating HPP. The other thing I want to touch on is that there's not only oral formulations, there are topical formulations of NSAIDs as well. The main one being diclofenac gel or Voltaren gel. Voltaren's a brand name. It's also available over the counter, but you can get it prescription as well. Sometimes if you have kidney dysfunction, your nephrologist may be okay with you using a topical NSAID because there's not as much systemic absorption, meaning that it's less likely to affect your kidneys. But just know that you do want to work with your nephrologist and your physicians to make sure that you're using these medications appropriately. Next medication is acetaminophen, or Tylenol, as we all know. This can, a lot of people kind of scoff when we think about the use of Tylenol. It's actually been proven to be really useful, especially when it's used in combination with other medications. So it can work synergistically, meaning that it doesn't just have its own independent a positive effect, but its positive effect not only adds to, say, an opioid medication, but actually makes both of them work even better than that. So that's why you might have seen some medications that are formulated with Tylenol in it. We do have to be very cautious with various side effects, especially liver damage, if you take too much. So this is the max doses for adults, so no more than 4,000 milligrams a day if you're using it just for a short amount of time, and no more than 3,000 if you're using it for a longer period of time. For pediatric dosing, I want you to talk to your doctor about those so I don't overgeneralize it. I talked about some topical medications like the diclofenac gel. Topical medications can be pretty helpful. I know that it's sometimes hard to think about, I'm just putting something on my skin. Is it really going to help? But the topical medications work in different ways. Some of them are absorbed and have some local effect there, but also it can also activate some other nerves or kind of quiet down the nerve activity locally as well. So there are positive effects not only just from the initial sensation. Well, some of the common ones are lidocaine ointment and patches, diclofenac gel, as we talked about before. Your doctor could prescribe some compounded creams that have different medicines in it, like gabapentin and local anesthetics. Those tend to be a little bit more expensive and often not covered by insurance, so just be careful about that. Capsaicin cream has also been helpful, especially in joint pain as well as neuropathic or nerve pain, so neuropathy. And over-the-counter topical agents like BioFreeze and Icy Hot, those things are great too because there's not a lot of side effects from them. They can be used chronically. So I encourage patients to find something that really can symptomatically help them. You've also noticed I tried to use mostly generic medications here as pictures. I always encourage people to use generic medications if they can because it's cheaper. It's usually the same product. So, and I don't need to be advertising people, but apparently I decided to advertise Salon Pass. So apologies for that. A huge group of medications are neuropathic pain medications. So those are the ones that are prescription. And those help modulate pain signals. So the idea behind these is that they kind of stabilize nerve membranes and decrease nerve pain transmission. That's why when you think about their mechanism, they usually fall into two categories, which are anti-epileptic or anti-seizure drugs and antidepressants, because it's kind of helping the nervous system calm down a little bit. The ones that you usually see are gabapentinoids and other ones on the anti-epileptic side. Gabapentinoids include gabapentin and pregabalin. These medications can be really helpful, and there's also not a small, but a manageable side effect profile. So there is potential for a lot of benefit with not too many side effects. Those side effects can be fatigue, changes in mood, and then it can also, it doesn't really necessarily affect your kidneys, but you do have to change the dosing if there's kidney function issues. A lot of people think that this is because it's monitored. So a lot of states have a prescription drug monitoring program that's typically for opioids and benzodiazepines and other kind of more dangerous scheduled drugs. Most of the time, gabapentin and gabapentinoids are monitored, meaning that they're just tracked through that. But they're not necessarily because they're highly addictive or super, super dangerous. So I don't want you to be afraid of it if your doctor decides to recommend these because it's through that monitoring system. It's generally not very addictive. There is a kind of an onset period, a titration period up and down so that you don't have withdrawal symptoms and other side effects, but it should not be addictive. Those are just some more examples of other anti-epileptics that have been used in neuropathic pain. Now, the other side of neuropathic medicines are the antidepressants. And the beneficial thing about this is that not only can it potentially decrease your pain experience, but it can also affect mood. And as we know, mood can be significantly affected not only by chronic disease, but also by pain. The categories are often tricyclic, so you might have heard of amitriptyline, serotonin, and norepinephrine reuptake inhibitors like duloxetine or Cymbalta, and then kind of traditional antidepressants, the SSRIs or the selective serotonin reuptake inhibitors, and that's like Prozac and Zoloft that we tend to use in pediatrics. Let's see here. Now, opioids. Everybody thinks of opioids almost instantaneously when we're thinking about pain management. And not only did I talk about this towards the end of the medications because it's at the end of the opioid or of the ladder that we use to help guide our pain treatment, but we really do want to be really careful with opioid use. The function of opioids is they basically bind to various opioid receptors, mostly the mu receptor. And these are kind of synthetic analogs because our body actually makes natural peptides and stuff that actually bind to these receptors naturally as well. Because of that, and because of this binding, you can have decreased pain because it basically kind of blunts the pain sensation, as well as it also kind of blunts the reactive affective part of pain as well. So it kind of makes you care less about the pain a little bit or kind of decreases the unpleasantness of the pain. People often think that, oh, this changes my pain completely, and it really doesn't have, it's so effective that I need to use it. But unfortunately, we have found that opioids often don't work that well for chronic pain. They're extremely effective for moderate to severe acute pain, like with fractures or surgeries and stuff like that. But when we use it chronically, there's a lot of untoward or bad effects that happen from chronic use. Not only does your body become adapted to this amount of synthetic opioid that's coming into your body, so it gets kind of dependent on it. So that also helps you create a tolerance to it, and you have to increase your doses. It also leads to something called opioid-induced hyperalgesia. So we kind of talked about how our nervous systems can be sensitized in the future with chronic pain. Well, with chronic opioid use, our bodies also can become sensitized to pain. Part of the reasoning behind that is that our body ends up making more of these opioid receptors, or opioid receptors in general, and then our body needs more of the medication to do so, and that can often decrease those really beneficial side effects of opioids, which is not caring about the pain and having a blunted pain response. So it's usually not indicated for chronic pain unless we've gotten to a point where all of our other medications and stuff have not been helpful, and it's really kind of a last resort. Now, why is it a last resort? I've talked about a few of those things, but one of the biggest things is there's a lot of opioid-related deaths, right? This is usually from respiratory depression because activation of the mu receptor can cause us to stop breathing. And it's not always due to an overdose of medications. It can be due to concurrent illness, causing our bodies to be more sensitive to these opioids. It can be changed into a metabolism, or it can just very well be that you've taken too much. When we're thinking about respiratory depression, there are other medications as well that can be helpful in pain treatment that aren't necessarily, that have a decreased risk of respiratory depression. And that's the graph that I have here, where you have a full agonist. Those are things like morphine, oxycodone, fentanyl, things like those. Those have the full effect of the agonist. So it really causes very profound pain relief, but also has a high risk of respiratory depression as well. There are other medications out there that being used a little bit more often, like buprenorphine. That is a partial agonist, so it doesn't completely activate that opioid receptor, but still can produce a profound pain response or pain effect, but can have a ceiling effect, meaning it doesn't necessarily always lead to respiratory depression like our other medications do. Now, thinking about our other side effects that opioids can have is that not only can it affect your mood in the long run, short term, it can decrease pain, anxiety, and depressive symptoms, but it's been shown to, even after 3 to 5 days of opioid use, it can actually lead to increased symptoms of anxiety, depression, and other mood changes. It can have hormonal changes as well. There's various hormones in our body that kind of help us grow, like muscles and things like that, that can be affected by chronic opioid use, as well as androgen production. So the androgens are kind of like testosterone and the kind of male sex hormones that we think about. So it can decrease that in our body and lead to need for supplementations and the side effects of those. The other thing I just want to touch on is tolerance, dependence, and addiction. So I briefly mentioned that tolerance is when your body becomes a little bit more, it's an expected part of opioid use, but your body is able to tolerate a certain amount and may or may not need more. Dependence is where your body has become so adapted to taking these outside sources of opioids that when you stop taking them, you might develop withdrawal symptoms. And then addiction is separate from those as well. It's when the abuse or misuse of opioids has other untoward effects, especially physically and psychologically, and to your psychological and family life as well. Just an overview of opioids. I know it's the thing that we primarily think about, but there are significant side effects for it, especially on long-term use. So we really want to be careful when we're using opioids. This is why your doctor may be very hesitant to often prescribe opioids, because they're thinking about all these things. It's not necessarily that they're being cheap or don't want to use it or don't want to prescribe it. It's that they're trying to be pretty mindful of using these. So we often say that opioids are indicated for things, major things like fractures, surgery, and for a short period of time, ideally. There's other adjuvant medications, so not necessarily pain medications, but things that can help. Muscle relaxants are an example of them. They can be really helpful with any type of muscle spasms that can be related to just deconditioning, but also like fractures and other things like that. Really caution with sedation, respiratory depression, especially when used at the same time as opioid medications. And then there can also be withdrawal from these that can be life-threatening, especially if you're on baclofen. Baclofen can be very, very helpful, so I don't want you to think about it as a negative, but if you're on it for a long time, you do want to work closely with your doctor to slowly come off of it if you decide to do so, because the withdrawal symptoms from it can be life-threatening as well. Anxiolytics can be really helpful because of the mood symptoms that are associated with pain and chronic disease. And some actually have some muscle relaxant effect, especially diazepam, also known as Valium. But we do want to use those cautiously as well because there's a lot of side effects with those. So again, something like Valium is often reserved for large injuries, surgeries, and whatnot. Clonidine is another one that you might have thought of. That's a different mechanism for decreasing anxiety, but with clonidine actually has been found to improve some of the effects of opioids and may have its own independent pain benefits as well. There are some other medications, and I'm not going over all of them today, but you might have heard of ketamine as a medication for pain. We often use that in the operating room or in the peri-surgical experience, but it can also be used as an outpatient. The evidence behind this is still emerging, so it's not something that I suggest all patients to explore, but it is something that can be helpful because it targets a different pain pathway, and if we're on opioid medications, can often decrease opioid medication use. Low-dose naltrexone is another medication that you might have heard of. Naltrexone is classically a medication that reverses the effects of opioids, especially respiratory depression effects. But when used in a low dose, it can actually stimulate our body to make some natural painkillers, so endogenous enkephalins and endorphins and whatnot. And so some people are using these more often. Again, the evidence for this is also still emerging, so there's not strong evidence behind it, but I just wanted to mention it. And then lidocaine infusion. So lidocaine is a local anesthetic, so a numbing agent as we think about it, but it can be administered IV to the whole body and may have some neuropathic pain effects as well. Again, the evidence behind that is also middling, so not a strong recommendation, but these are other things that might be recommended by your physician. I'm not going to talk too much about other alternative naturopathic medications. I think a lot of people think about CBD and THC products, so cannabis products. There can be potential positive effects from that because the endocannabinoid system is throughout our body and has many, many effects that we know some of them but don't know all of them. So it's potential, there's a lot of potential for these medications to have positive effects on pain sensation, mood, maybe immune response, possibly sleep as well. But again, these are not thoroughly researched at this time, especially since this is still illegal federally. So since there's no research, it's unclear how effective they actually are. We don't know what the side effects are. They're not regulated by the FDA, so every compounded cream or tincture or oil are very, very different from each other. So it's not that we don't recommend people to use these, but we can't outwardly recommend people to use them as well for all of these reasons. But they exist out there. There is more emerging research from this as well, so we'll see what happens in the next 5, 10, 15 years. As pain doctors, we are also trained as interventional pain doctors. So you might see that specified in most adult pain doctors now because most of us are trained more so in interventions rather than medication management. Not all pain doctors just prescribe opioids. That's usually one of our less preferred parts of our job is prescribing chronic opioids because of all those untoward side effects and whatnot, because we can potentially help a lot of pain with various nerve blocks and various joint injections and whatnot. In HPP, I would say that most likely some of the injections that would be done are more like joint injections, especially with calcinosis and calcium pyrophosphate deposition. So that often may be done by a orthopedist, a PM&R doctor. It can be done by a rheumatologist or a pain doctor or other specialties probably even as well. But these are another part of the pain treatment that's possible. So just re-emphasizing that pain treatment is interdisciplinary. I talked a lot about medications because that's my part of the picture, but really wanted to emphasize that there's other parts of the picture as well. So medications are a small part of it, aside, of course, from the primary focus, which is treatment of the HPP when possible. So when we think about other therapies, non-pharmacologic therapies that we can do, there's various things that we can do from a physical activity standpoint, brain-based standpoint, lifestyle modifications, and alternative therapies that can be very helpful. Some of the things that I obviously recommend are PT, OT, aerobic activity. Aerobic activity doesn't have to be running or jogging. It can be simply walking. And it can be simply walking for your tolerated amount of time at first. So sometimes we start patients at 5 minutes and then slowly progress from there. Brain-based therapies, that's where you're going to often work with a pain psychologist. These can be really helpful to not only help you relax and improve your pain experience, but actually use your brain in different ways to send descending signals to where you're having pain and hopefully decrease that pain experience. There are many alternative therapies that can be helpful. Acupuncture has been studied in Western medicine, so that actually is really, really helpful. So if you can find an acupuncturist that you like, and that can be really effective. Hypnosis as well, surprisingly. So I'm not just putting it up there just for fun. And then lifestyle modifications in general can be really helpful for pain. Sleep is one of the most important predictors of pain severity. So working on your sleep can be really, really helpful. I won't go through all those things, but even though they sound silly, like turning off your screens, not taking naps so that you have better quality of sleep at night, those things have been life-changing for a lot of our patients. Really maintaining a daily schedule so your nervous system knows what to expect instead of being surprised all the time can help set up your nervous system for success. And then one of the things I want to really emphasize is reducing hypervigilance. So one of our natural tendencies is to check in consistently with our loved ones on whether or not they're having pain at this moment or on this day and whatnot. That can also often be triggering and actually increase that nervous system being sensitized to pain. So I'm not telling you to ignore your loved ones that have pain, but it can actually worsen their pain experience if we're checking in all the time. So I just want to talk about that. Again, we're thinking about this from a biopsychosocial standpoint and an ecological standpoint, so it really involves a huge team, and we talked often today about how important a multidisciplinary team is to HPP, so pain is one part of it. And that's it. Just want to thank my team that I work with on every week, from our pain psychologists to our occupational therapists to our PTs and our leadership at Vanderbilt that is always in support of our program.